Welcome to Oncology for the Inquisitive Mind, another OncoSnacks edition. This time we have a special guest, Dr. Mark Nolan. Dr. Mark Nolan is a non-invasive cardiologist with a strong interest in cardio-oncology and advanced cardiac imaging. He has an echocardiography fellowship from Adelaide, an advanced cardiac imaging and cardio-oncology fellowship from Toronto. To top it all off and to ensure that we know he never sleeps, in 2021 he completed his PhD in cardio-oncology and has published in all of the journals, including Canadian Journal for Cardiology, American Heart Journal, International Journal of Cardiology, and Internal Medicine Journal. We are so grateful to have you here, to Mark, to spread your pearls of wisdom. Thank you again for being on the show.
Oh, thank you for inviting me.
So Mark, I think we would like to start with the oldie but the goodie, which is anthracycline associated cardiotoxicity. We, even in basic physicians training, people are taught a little bit about this, but obviously we're assuming that there are so many more intricacies to how it presents, the permanence of cardiac toxicity associated with any chemotherapy ending with rubicin. So in your experience, when you have a patient that is referred to your clinic, usually a breast patient, I'm assuming you would get maybe the occasional sarcoma patient or other histologies, but if they're coming to you, they've had X amount of anthracycline and they've presented with heart failure symptoms, or they've had I almost said a restaging echo, that just shows how set I am in my terminology, but an echo that shows new reduced ejection fraction. Can you just tell us your experience and what you generally do with these patients?
Yeah, definitely. So anthracycline cardiotoxicity is still very much a thing. It seems to be about 20% of patients might develop a small ejection fraction drop, more than 5%, and about 10% actually develop a significant drop, which isn't always symptomatic. So you have to sort of have a high suspicion for it. And we often see that although you can get the LV drop usually in the first 12 months, the risk of heart failure over the next few years increased 3 to 5-fold. So it's quite a dramatic risk factor. What do we do when we get the patient whose LVEF is starting to drop? Well, the first thing that I always want to do is, if you can, identify the high-risk patients before they get that first drop of anthracyclines. So the best way to prevent these patients from developing heart failure is just do the simple stuff first. Control their blood pressure. 160/80, we can treat that. We can put them on antihypertensives and bring it down. If they're smoking, we can treat that. In some cases, we may even manage their cholesterol, and there's some good evidence that statins can prevent LV dysfunction as well. Then you want to monitor them. You want to make sure the ejection fraction doesn't drop during their chemo. There's a few ways to do that. Echo is probably the best way. There's two ways you can measure the ejection fraction with the echo. There's a 2-dimensional technique and the 3-dimensional technique. They can both be done by the same machine, but they need different probes. And there's a little bit of, the operator and cardiologist needs to have a little bit of experience to do the 3D technique. And that's really the ideal because it's more reproducible. Now, with 2D ejection fraction measurement, it's a good test, but it can be off by about 10%. So hypothetically, Michael, if I did an echo on you today and I had an ejection fraction of 54% and I did it tomorrow and it was 65%, or has your heart gotten better? Probably not. It's just probably that retest probability. So with 2D, you need to see a bigger difference before we can say it's a real difference. 3D is a little bit more reproducible. If it's more than 5%, then you can say there's a real drop. And of course, cardiac MRI is it's the gold standard. It can really pick up very small changes, but of course that's not always accessible in every centre. We're starting to move away from, we're trying to recommend against using Muga scans for the LVEF measurements. We've got to be realistic. We understand that oncologists need the measurements quickly. We want to start the chemo fast. You don't want to wait to have their echo next month. But the Muga it's not as accurate as we used to think it was. We've done some studies comparing it with MRIs, and we find it can be off by 10, 15, more than 15% sometimes. So it can be quite considerable. What do we do once the ejection fraction's actually dropped? Well, really, you want to try and keep the chemo going if you can. If I usually advise at least a pause in the anthracyclines if it's dropped less than 50%. And I usually start treatment as quickly as possible. The standard treatments are the ACE inhibitors and the beta blockers. So I might usually put them on ramipril and bisoprolol, get them back every 2 or 3 weeks, so ramp the doses up to the maximum dose. And then I try and repeat the echo in 6 weeks to make sure the ejection fractions and the cardiac function's moving up and not going down. One little tidbit I'll use is it's always, whenever you get an echo, it's always a good idea to get a global longitudinal strain, which is a measure of subclinical function. It's a measure of how well the heart's actually deforming. And that can actually give you a better idea if your cardiac function's getting better or worse. It's a bit more reproducible than the LVEF. So, and ideally, once you've got beyond the treatment, the heart should get better.
I think one of the questions we might have is being, I'm a breast fellow, so I deal with anthracyclines quite a bit. Apart from baseline, how often would you recommend to do an echo? Because these treatments, yes, I mean, dose-dense AC, which is the doxorubicin part, it only goes for really 2 months, right? So, or maybe 3 months if you make the non-dose dense. Like, do you have a recommendation during treatment? Would you do it every 2 months to check, especially if they're young?
Yep, I probably would. It depends on the patient. The first thing I'd want to know is a risk. So if you've got a 40-year-old woman with no other medical history, I might just do a baseline, and then she's getting anthracyclines. I might just do a baseline echo and maybe just an echo at the end, just to make sure that her heart's function's going well. But let's say I've got a 67-year-old lady, she's diabetic, she's hypertensive and not well controlled, and she had a stent put in her heart 3 years ago. That's someone I'm going to be a little bit more worried about. So with that patient, I would usually recommend getting an echo every 3 months up until the end of chemo, or even up to 12-month period. And then I'd probably recommend getting an echo maybe at 12 months, 3 years, 5 years afterwards, just to make sure that LV function stays stable.
You mentioned the discrepancies between MUGAs and echoes, and gave some very practical considerations, I guess, why we sometimes reach for the nuclear medicine heart test in place of an echo. Is it reasonable, say there's as you say, a time period to start someone on chemo? Is it reasonable, and is there any sort of acceptable, or is this acceptable, I guess, to have a MUGA to start as a baseline and then follow it up with subsequent echoes, or is the discrepancy too wide and you really need to do the same scan?
It's a challenge. My preference is that you really want to have use the one modality throughout the anthracycline treatment. The problem is if you get a MUGA scan for one time point and you get an echo at another time point, or an MRI at another time point, they're really not comparable. They're giving different information. They usually, there's a bit of bias. One technique always measures a little bit higher or lower than the other technique. And you're not really sure how to sort of, what direction the patient's heart's going in. So my preference, and I know it's a sort of living in an ideal world, is just try and use the same technique if you can. If they're going to be, if they're high risk and they're going to be getting a lot of LVEF measurements, I would probably recommend getting an echo and using that as the preferred modality.
Mark, with your research, and I'm not sure if other people have done this research, in the high-risk population, do you preemptively start patients on, let's say, beta blockers or ACE inhibitors to reduce the risk of anthracycline-related cardiac toxicity?
I don't at this stage. I don't think we've really got enough evidence to adopt such an aggressive approach. Of course, if someone's got a reduced ejection fraction, say between 45-50% before they get anthracyclines, I may try and start them on ACE inhibitors and beta blockers and then see if we can get them up to a point they can have chemo. Those are ones you may also consider using dextroxoxane, which is an agent that protects against anthracycline cardiotoxicity. Not used much, but is a very effective agent when used. We sort of use it in patients who have had reached challenge with anthracyclines and they've had very high doses before, or they've had some LV dysfunction before. But usually I try and use an adoptive approach. So basically, provide the ejection fractions above 50%, then I'll just watch them with echoes and wait. And provided the ejection fraction remains normal, I probably wouldn't use ACE inhibitors and beta blockers. What I might do is I might use a more aggressive surveillance technique. So if you've got that 65-year-old patient and their strain is abnormal, so they've got strain of minus 14%, which is a risk factor, even if the ejection fraction's between 50 and 55%, I might just say, hey, let's get an echo 6 weeks after the chemo, and then 3 months, and then every 3 months after that. And I might add BMPs and troponins as well, biomarkers, which are a little bit less specific, but can sort of determine if the patient's taking a high-risk trajectory or not.
Mark, you just answered my question about how far you sort of wait for the ejection fraction to drop before stepping in. I'm assuming also that if the second they have symptoms or signs of heart failure, regardless of what the EF is, you would also consider stepping in pharmacologically at that point as well?
Absolutely. Once they've developed symptomatic heart failure, that's a very different ball game. These are the patients who have very high mortality. So I would treat that patient very aggressively, and I'd want to have a multimodality meeting to discuss whether we should continue with anthracyclines or not. I would certainly encourage the oncology team to consider other options if they're available. But one thing I'll just quickly point out, we talked a lot about anthracyclines, but with trastuzumab, we're now aware that we don't always have to stop the trastuzumab when they develop a slow drop in the ejection fraction. We've had several small studies that suggest if the ejection fraction remains above 40% and the patient's asymptomatic, should probably continue Herceptin without any pause, provided you treat them aggressively with ACE inhibitors and beta blockers.
And why is that? Why is that? What's the theory that by not stopping that you can? Is that just the preventative measures of the medication that you use?
The Herceptin cardiomyopathy does seem to be relatively more benign and does tolerate a slight dip in the ejection fraction better. It seems to be due to a cellular mechanism. What Herceptin does is it blocks HER2 and the new regulin pathway, which is a repair pathway. So it sort of impairs the heart's body to repair itself, whereas anthracyclines actually work on topoisomerase, they create free radicals. It does seem to be more damaging. So an ejection fraction of 45% from anthracycline seems to portend a worse prognosis than an ejection fraction of 45% due to Herceptin. They both merit treatment. That both patients I'd see regularly and push their ACE inhibitors and beta blockers up. But the one thing that us cardiologists really don't want to do is stop chemotherapy unnecessarily. We're very aware that chemotherapy saves lives. Even a slight pause can reduce the risk of beating cancer. So if there's a path to getting them through their chemo without any missed doses, and that's the path we prefer to take.
And is that discrepancy in prognosis between anthracycline cardiomyopathy and trastuzumab-associated cardiomyopathy, is that sort of I don't even know it's a myth, but in BPT we're always taught, anthracycline cardiotoxicity is irreversible, whereas trastuzumab is reversible. But I think in both of our clinical practices, we've realised that it's not necessarily that hard and fast. But is that where that sort of idea comes from?
There seems to be some signal that Herceptin cardiomyopathy may be a little bit more reversible. But like you said, there's always a dozen exceptions to either case. I've certainly seen a lot of Herceptin cardiomyopathies that have improved with treatment if you catch them early. I think one take-home message is regardless of whether it's anthracyclines or Herceptins, you really want to try and catch it early, which is why the high-risk patients we recommend doing 3-monthly or in some cases even 6-weekly echoes.
And with the newer generation of HER2 agents, I'm talking about the trastuzumab emtansines and the trastuzumab deruxtecan and all of those that are on the horizon. I'm not sure if your research went into that, but can we continue those treatments given that they've got higher potency? Do you more recommend that you sort of stop that if you see a drop in the ejection fraction?
Yeah, I have to admit I'm not aware of the very latest research on this. What I sort of remember from the talks and the conferences I've been to is that these agents seem to be a little less cardiotoxic than Herceptin. We sort of think the cardiotoxicity may be an off-target effect through the neuregulin pathway. And these newer agents are a little bit more specific and have higher affinity for HER2, maybe less likely to cause those problems. So hopefully we'll have the studies come out to show that's true. But I think the same process applies. Provide the ejection fractions above 40%, keep their life-saving chemo going. And if the heart function drops, don't be afraid to start ACE inhibitors and beta blockers and any other heart failure treatments that may benefit the patient.
Mark, we've talked a lot about treatment, aka what to do when things kind of go a bit pear-shaped, but you mentioned earlier about cardioprotection, and you name-drop statins as a potential therapeutic class that might have some cardioprotection. Do you have any pearls about ways to, as you said, we work up the patient, we isolate the high-risk patients. But do you have any pearls about what budding oncologists could do, even say before referring to a cardiologist, in order to reduce the risk of encountering problems?
Yeah, look, I think basically you just want to get a good baseline cardiovascular risk. There are several calculators that you can do. I always recommend just measure the cholesterol if you can. It doesn't have to be fasting. Just a random cholesterol and random LDL is probably as good as a fasting one. Measure their blood pressure. I personally throw that into a little online calculator called the ASCVD calculator, and that'll give you the patient's risk of having a heart attack or stroke in the next 10 years, depending on what the blood pressure, smoking history, cholesterol is. If it's more than 5%, I might actually consider organising a calcium score for the patient. The calcium score is just a CAT scan, doesn't have any contrast, very small amount of radiation, and you can actually measure how much calcified plaque is in the heart. And the idea being, if that's high, if that's more than 100, this is probably a high-risk patient, and you should probably just put them on a statin straight up. And there is some evidence that statins may actually protect the ejection fraction of the heart during chemo as well. But I think it all just comes down to, we know the heart's going to take a kick from the chemo, so you really just want to optimise the heart overall health. Blood pressure and identifying those who benefit from cholesterol-lowering medications, optimising their diabetes and their lifestyle. These are all the things that can make a difference right from day zero.
Mark, you've got so many pearls of wisdom when it comes to these things, which is wonderful, because I can very much remember the first patient I've had on Herceptin, and I'm like, you kind of sit there, deer in headlights, wondering what to do. For all of our listeners out there, medical, oncology, or otherwise, do you have any other tips that we might not have mentioned today that you think would be worthwhile from either prevention or management perspective of these, I guess, this high-risk cohort of patients?
No, look, I think the most important point is just to have the cardiologists and oncologists working well together. Encourage us to attend each other's meetings, give presentations, and be on each other's mobile phones and accessible. So if you've got any questions, just you know who to call and who to ask. I've got about 10 oncologists' mobiles on my phone, and I often give them a call when I sort of have a question about the chemo that the patients are getting, and I always have time when they call me. And I think that's really just how you get a good service going, and how you prevent the cardiac complications from building, just from being accessible and there when the team or the patient needs you.
Mark, thank you so much for coming on. As Josh said, I don't think we've ever had a guest that has dropped so many pearls of wisdom in such a small space of time, and just so casually, here's one, here's another. Every sentence seems to have so much helpful information. So thank you so much for coming on. We really appreciate you taking the time.
It's been a real pleasure. Thank you so much for the invitation.
Wonderful. For our next episode of Oncology for the Inquisitive Mind, OncoSnacks, we will be discussing the eternal challenge of peripheral neuropathy related to chemotherapy. So we hope to see you then.